Well, welcome to Simulation Pulse Live. Today we have a very special guest, Dr. Nick Slamon. He's from Nemours Dupont Children's Hospital in Wilmington, Delaware. He's been a longtime collaborator and a friend of ours, and really excited to have him as a guest today to talk about some of the most recent work that he's been doing. But you might remember Dr. Slamon from all different kinds of 3D recordings and simulations that he's been building in Acadicus over the past coming up on 6 years. And today we're also joined with Bill Ballow from Madison College. We've got Shan Blissett, one of our developers at Acadicus, and we've got Rick Castille, our customer experience specialist. I'm Jon Brouchoud. I'm the founder and CEO of Arch Virtual, the developers of Acadicus. Oh, and we have another guest joining. Dr. Kalbach is here. So while Dr. Kalbach is joining, I'll just say that it's kind of full circle that Dr. Slamon and I met at IMSH. I think it was 2019 now, so coming up, it's been quite a while. And of course, like I said, he's been responsible for building some really exciting simulations in Acadicus, but most recently developed an ECMO simulator together with Dr. Kalbach, who just joined us here. Welcome. And today, so he actually presented that. He and Dr. Kalbach presented that at IMSH this year in January, and also were able to present at the Innovations in Medical Education at USC, and just invited him on the Pulse to talk about the simulation. And there's a couple of other things, a lot of different things we can talk about today, but I'll leave it at that and turn it over to Dr. Slamon and Dr. Kalbach, and we'll go from there.
Awesome. Thanks so much, John. So I think the place to start is, and I'll defer to Dr. Callback as the expert in a second, but when simulating ECMO, there's a lot of things to consider. And just very briefly, ECMO is extracorporeal membrane oxygenation. A lot of people will think of it as the heart-lung bypass machine. I think folks that lived through the COVID pandemic when folks were very sick and on ventilators experienced an uptick in the use of taking the blood out of the patient, putting it through a machine that added oxygen to it, and then pumping it back into the patient. And to simulate something that is very high acuity and very technically demanding, but doesn't always happen very often unless there's a raging pandemic, is very difficult for hospital systems to do. Most places will use a real ECMO circuit that is not being used for a patient at that time. They'll hook it up with water and food coloring, and they'll rig different bladders to it. They'll try to attach it to a mannequin, and they will try to simulate the various scenarios that could occur when a patient goes on to ECMO, while they're being maintained by the ECMO pump, and then when they come off. So it's a really labor-intensive process to prime the entire circuit and maintain it. It's also difficult to try to coordinate a large group of people into a very small space so that they can all see and interact with ECMO. And I think the other thing to keep in mind is that at any point, if a real patient needed that pump, everything has to be torn down, cleaned, sterilized, and quickly moved to the ability of the patient to use it. So you kind of never know. There's lots of planning that goes into these ECMO simulations. Folks may be coming from other hospitals a long distance to learn how to do ECMO. They might not have it at their hospital yet. And at the spur of the moment, there could be a call saying the ECMO simulation is canceled. Sorry, you flew in here, but we need the pump for a real patient. So to be able to do this in virtual reality with very little setup, to be able to add a level of realism by removing the plastic mannequin, and to be able to have a fully functional ECMO circuit that we can control every parameter was the goal of the project. As far as the use of pediatric ECMO, I want to pause here and kind of turn things over to Dr. Callback, and he can give us some of the reasons why we would need this, what the indications would be to put a patient on ECMO.
Thanks, Nick. I appreciate you. So, so in the realm of ECMO, when we're talking about either pediatric or neonatal ECMO, usually the most common indications in those instances are any form of either lung infection or lung injury that's not allowing the body to get adequate oxygen or not allowing you to ventilate appropriately and is either causing hemodynamic instability or it's causing issues with delivery of the oxygen to the tissue level. Some of those instances may be caused by infection. Sometimes it's during the birthing process where maybe the lungs are exposed to meconium when they are first being born. Um, Or you might have severe infection, right? As Dr. Slamon was saying earlier, this is either a lung or a heart-lung bypass machine. So we can just support the lungs and help do the bypass from there and rely on the heart to function. But sometimes the heart doesn't function well in instances like sepsis or maybe myocarditis, where there's an actual inflammation or infection that's affecting the heart. And in those cases, we can actually help perform the function of the heart through this mechanical circuit, whether it's by a centrifugal or magnet-driven pump or an actual roller head driven pump that can give us that flow that we do require.
Awesome. So again, to kind of create the complexity that we needed, we partnered with the Acadicus team. Dr. Kalbach secured a internal grant from Nemours to help us design the circuit and pay for the building of the circuit. And again, realism was important to us. We really wanted to be able to simulate a range of patients that we might have to take care of. So we built two simulators, one an infant, which, as Dr. Kalbach referred to, around the time of birth, and especially infants with congenital cardiac disease, lots of those patients need ECMO support. So we definitely wanted to have an infant that we could simulate with all the way up through a teen patient, which may need ECMO for any of the reasons Dr. Kalbach mentioned, bad infection, things like flu, things like COVID. They could have an infection of the heart and myocarditis and need both um, respiratory and cardiac support, ECMO. COVID is another common one. Asthma is another common indication for ECMO where the oxygenation part of the lung seems to work okay, but the ventilation, the carbon dioxide level builds up. So at this point, it might be the best idea, Jon, to join Rick in the ECMO room that we set up with the teen patient, and we could go over some of the basics of how the pump works and what we were going for.
Good.
Awesome.
Do you want to lead the tour or do you?
Say that again, Nick.
Oh, sorry, I was just saying, did you want to lead the tour through or did you want me to
Yeah,
pick it up
if
from
you
here and
wouldn't
kind of go
mind,
through everything?
yeah, if you wouldn't mind kind of tracing the path from the cannula in the neck through the machine and back, that would be awesome. And as you can see
Be
on the
more than happy
screen,
to.
there's a lot of incorrect check marks. Part of what we're hoping to do with this is not only be able to simulate different scenarios, mock code scenarios, but also train the folks that have to care for patients that are on ECMO, whether they're the technicians that manage the pump, or the nurses or respiratory therapists that are managing the patient, or the residents or fellows. What we're hoping to do and what the incorrect check marks are is kind of a mistake room or a mega room with mistakes in it. And what we'd like to have those folks do, especially folks that haven't had a lot of exposure to ECMO, is go through the circuit using the circuit checklist and find mistakes, find areas that they say, this isn't right, this isn't what it's supposed to be. So I took the liberty before this Simpulse today to go ahead and make some mistakes, create them with our Sim Manager controller, and then label them. But the idea would be that the folks that are being exposed to ECMO for the first time and trying to learn about it would follow the checklist. They'd have these incorrect buttons that they could grab with their hand controller and place on the patient in various areas where they see a problem.
Awesome. Look forward to seeing them as I go through, Nick. That's great. Um, So I presume, Rick, you're going to be my my visual guide in order to get people seeing what they need to see. But as Dr. Slamon was saying earlier, this is our late teen pediatric patient who is currently, based on everything I'm seeing, looking like they are on VV ECMO, most likely. If we were to actually get a little bit closer from a camera standpoint towards the actual cannulation site. So, as we said earlier, there's two forms of ECMO. There is VV, which is veno-venous, which is a form of lung bypass where we drain blood from the venous system, most typically somewhere along or near the right atrium or one of the major vessels. And we return it back into those major vessels, typically closer to the heart, where the heart would actually be performing the cardiac output for the patient. And with that, the heart and rest of the system would be getting the oxygenated blood from that system and traveling around. So, starting from the neck, one of the most common cannulation sites when we talk about single site cannulation, what we typically use is a dual lumen catheter. This catheter both has drainage as well as return capabilities, all wrapped into one. This will typically get inserted at the right internal jugular vein. And it has drainage ports both proximally and distally to drain from both the superior and inferior vena cabas. And then the return port is usually typically around the level of the heart that allows the body to pump the oxygenated and ventilated blood through. So from that actual cannulation site, you can see the blood. Right now, it looks like we might be recirculating, which is a common phenomenon that we see, where because you have this cannula occupying the same vessel that you are both draining and returning to, sometimes those drainages can happen at the same time essentially you are draining from the return blood. So sometimes that can happen and you can look like you are draining oxygenated blood from the patient, but sometimes that can be appropriate. Well, I shouldn't say appropriate. Sometimes it can be acceptable, and other times that is an issue that we can actually simulate in this. So, if you were to take it from the venous port, you would essentially go from the neck up into what you can see as the simulated circuit. This will flow through towards this cylindrical type of apparatus, which is actually our the driver. That is the part that has the magnetic propeller that is going to actually move the blood. That is coming around and into the diamond shape whatchamacallit portion or apparatus that is here, that is the oxygenator. That is what's performing both the oxygenation and the ventilation of the blood that is drained from the body. It is then, after it goes through this oxygenator and interacts in a microfilament level with the air that's passing through it, it then travels back into the patient up to the site that you see, and it goes back into the return port that I mentioned earlier, goes back to the right side of the heart to be pumped through the rest of the body. Then if you actually pan over to the right, you can see the actual control unit for our ECMO simulator. You have different screens that will give you vital statistics having to do with the pump. That's going to be right now in the upper right portion of your screen. That will tell you the amount of flow that's provided to the patient. Perfect. You can see there's numbers such as SVO2, which stands for the mixed venous O2. That's the saturation of oxygenated blood that is coming back into the circuit. Typically, in someone who is recirculating, that is going to be much higher. But you also see that they have the amount of flow that's going to the patient. The square box that's kind of more towards the center of the screen as of right now, that is the actual driver or motor head, you could say, for For the pump that I showed you, that was the cylindrical item earlier. And there is where you can actually adjust the RPMs, or the amount of spin that's occurring in the propeller. That will essentially drive your total blood flow. And essentially all you have to do is just move that slider with the pump, and that will give you increased or decreased flow depending on what your issue is. Your screen on the right is going to have, again, your total flow as well as your RPMs. It also gives several different pressure monitors that can give us a lot of information about the patient's current status, including how hard the machine has to pull to retrieve the blood and return it back to the patient. Slightly above those, you can see with the Acadicus logo is going to be our controller of both the amount of oxygenate, or oxygen, I should say, or air. We call it sweep, that is being provided to the patient, as well as how oxygenated that sweep is. And that is what's going to actually interface, thank you so much, with the blood over at that diamond-shaped oxygenator. And then you can see we have our oxygen tank, which is always available to us in case we have gas failure. And we also have a spare drive head that's there on that middle shelf. And all the way at the bottom is a warmer, essentially, that will help maintain our patient's temperature, since they have such a large amount of their blood volume flowing outside of their body. So we use that in order to help regulate their temperature. We also have several different areas that you can interact with the circuit, including pressure monitors. We have pigtails that we use in order to deliver either blood products or perhaps sample the blood in order to do various tests to it. And we also have a bridge, which is a connection between the return side as well as the drainage side, that allows us to flow our circuits despite whether it's being delivered to the patient or not. And in those instances, we may be clamped off to do some sort of trial, and we want to make sure the circuit doesn't clot off. And then lastly, kind of going towards the back of the room, you can see a little bit of our checklist. This is a checklist that all of our ECMO specialists or resource physicians will use on a basis. It's our physical exam of our circuit, where we actually go through and check the different components to make sure that they are all operational and connected, so that way we can more readily troubleshoot in the event that something does go awry. And with that is actually interactable for each of our learners, where you can actually go through, you can check them off one by one, so that way you'll always have a reference, just like you would in real life, on each of our ECMO carts. And I'd say that's a pretty robust kind of tour and walk.
Awesome. Thanks, Nick. So, John, I think what's important to understand is this is probably the most complex project we've ever done with Arch Virtual and Acadicus. And we really wanted to make sure that every possible scenario could be simulated and be fully in our control, from failure of the pump, failure of the flow of oxygen, failure of the sweep gas, being able to change the pressure settings across the oxygenator, being able to change how fast the pump flows, how many RPMs does it generate into liters per minute of flow. We wanted to be able to have the patient bleed, have the patient clot, have air being trained into the circuit, which is a potentially devastating complication. We wanted to be able to make sure we could change the patient's vital signs by leaning on previous builds of Acadicus. So being able to change from a normal sinus rhythm to an SVT to a VTAC to a VFib, all things that could occur with a really sick ECMO patient and may need you to convert from a VV, just supporting the lung ECMO, to a VA where the lungs and the heart need to be supported. So we wanted to make this the most interactable and the most true to life simulation that we've ever built with Acadicus. And thankfully, you may think to yourself, this probably took 3 or 4 years. This took probably 8 months or less. Again, it really stood on the shoulders of things that Sean and Stefan and John had built before. So there was a plan for taking advantage of things like the sliders that can easily change the pressures or change the RPMs or change the temperature of the circuit. Um, being able to control the vitals monitor and the previous builds of the vitals monitor, where we could go from a normal waveform to an abnormal waveform in the click of a button. We wanted all of this to be out of the view of the people in the simulation. So the sim manager has control of all of this and is the upfront person being able to do it, but everybody else is reacting in real time to what they see. The patient becomes pale, the hemoglobin is dropped, the heart rate increases, the blood pressure falls, the rhythm changes. These are all things that, were built previously in the generation 2 patients that we took advantage of by using the infant mannequin and the teen mannequin. So I think at IMSH and at the International Medical Education or Innovations in Medical Education Conference, that was our goal, to truly communicate that we took something that's really complex and can be physically simulated, but takes a lot of lifting to do, and put it in a headset. And we're just kind of getting started. As I alluded to, all the incorrect buttons are things that we're planning for a study where folks can kind of come in and look for problems in the circuit by using the checklist and practice doing that. I think the second level of simulation, obviously, is the mock code, where we're on the fly in real time, have a team of people in headsets that are in the same ECMO room with us and managing the patient with common ECMO problems like recirculation, where both tubes look red instead of one blue and one red, or cutting out, where the machine is trying to pull blood out of the patient, but they're not able to generate the flow that we want them to generate. And there's a total number of things that could cause that: cardiac tamponade, pneumothorax. Um, we really wanted to be able to do all the different scenarios as well. And then I think the third piece of simulation that we haven't talked about too much is that there could be group learning, where we're not really doing a mock code, we're introducing folks to, this is how the pump works, or this is where the cannula should be placed, or taking advantage of Acadicus's recording function, we can create these self-directed learning modules. And if we have time, I want to introduce a couple of those in terms of point of care ultrasound rooms that we've created, where, okay, you have your own headset, it's a Friday afternoon and we're going to meet in Acadicus to talk about this, but you're not available. Well, you shouldn't have to miss out on that. And using Acadicus's recording function, I can self-record that same lecture, set it up as a module within this learning lab, and you can learn that at your own pace. And you can repeat that over and over again until you're really comfortable that you understand the material. So we've already built one ECMO module that's separate from the mock code. And that's, again, the cannula position, that double lumen cannula that Dr. Kalbach referred to, is really difficult to place in the right spot. And it really tends to be kind of a mystery for people about where's it supposed to be and how big is the cannula supposed to be. So we built a separate learning lab where, using the Acadicus 3D beating sectioned heart, you can grab that cannula with your hand controller, move it up and down until the infusion port is right where it's supposed to be, directing the flow across the tricuspid valve. And you can put your head into the 3D heart and see that it's all lined up, and that really makes sense for where you're supposed to be. That is the ECMO cannula module. Rick, if you want to switch over to that.
Just have to say, I think, what's really great about this project, by the way, fantastic work. I mean, I know our team has really enjoyed working with you on this, and it's just an incredible innovation here. And I think it takes advantage of a lot of the things that VR does really well. There's certain things that VR doesn't do well for medical training. We know that, certain haptic things or things that require fine motor skills just don't translate well. But, this sort of checks a lot of the boxes where I think it works well, where there's things that are expensive or complex or dangerous or impossible. And this is all of those, right? Like it's one of those things that it's very difficult to do in another way. It's a very complicated thing. It's very expensive, and it just checks all those boxes. And I think you also really took advantage of Acadicus and all the features that it has to build this and leverage those features in terms of, like you say, the 3D recording tool. You're not just putting somebody into a simulation. It's a 3D recording of you, of the expert actually describing it, which I think has a lot of value. But then there's also, so that's an asynchronous sort of use case, but then you've also got the multiple, participants. So for real-time interaction, the mock codes where you've got several people, like you just said, in there interacting in real time, that's a completely different modality. It's a completely different thing, but tremendous value there. So I think you really took advantage of a lot of different characteristics of Acadicus and VR in general. So great job. Fantastic simulation.
So speaking of features that we took advantage of, this is that kind of mini module that I just described, where how do you know where to put the cannula? How deep should the cannula be? Where should it be placed? And as Dr. Kalbach said, there's some infusion port that directs that oxygenated blood across the tricuspid valve. And then there's two ports at the top and the bottom of the cannula that are kind of sucking the venous blood out into the pump so that it can go across the oxygenator. So in this module, you can kind of put your head in the right atrium, see exactly where the cannula is lined up, and look across that tricuspid valve to assure yourself that the cannula is properly positioned. The other two features that this module I think highlights nicely is that we have in Acadicus a media displayer for static images. So X-rays, cartoons showing where the cannula should be properly placed across the back part of this module. And there's also a video displayer. So you can take short loops of video like an echocardiogram and really drive the message home for the learners that this is where the cannula should be, and this is where the jet of that infusion of red blood that's coming back from the ECMO circuit should be directed across the tricuspid valve. So just really good use of new technology that's come out in Acadicus in, I would say, probably the past year or so, the media displayer and the video displayer.
Excellent. Yeah, you've taken advantage of those in a great innovative way here. And that heart asset was an existing, so some of the content, the environment that we're in, the content is already in Acadicus, but you're combining it and utilizing it in an interesting way here to supplement that simulation. Very cool.
So, Rick, if we have time, if we could go to the POCUS room, and there's two of them. One is POCUS EF, and one is the POCUS cardiac POCUS tutorial. I think we could highlight one last kind of new innovation that we've added to try to increase the engagement of medical education in another topic that's, again, very complex. And there's lots of mannequin trainers and there's lots of YouTube videos and that kind of thing. But this takes a different take on it. And that's the use of both the video displayers, the media displayers, and the action button. So this is one of our fairly static mannequins that we've used many times in the past. He can be intubated, he can have a chest tube inserted. He's our, teen patient. But what we've used him for is that how do you do point of care ultrasound and how do you teach point of care ultrasound to a person that knows really nothing about how to do their own echocardiogram? And what we've been able to do is create these action buttons. So hyperdynamic and normal and moderately and severely reduced behind the scenes are all linked to other things. So it could be linked to the position of the probe on the chest. So if you click the button, it'll tell you where to put the probe properly. It could be linked to a video display that we can put on the monitor to show you what the typical echocardiogram would look like if it was normal versus if it was severe. We can create our own kind of quizzes within Acadicus where you can check your learning about how you understand the topic. We did that in a separate module with a very simple kind of pairing exercise where you would place the action button on the right anatomic part of the chest and pair that up with the echocardiogram view that would go with it. And then again, you could do all this live. So if you had a virtual reality lab like maybe Madison Technical College where you have 20 headsets and an instructor that's in the room with those students all in headsets, you could have that expert lecture live. But let's say you have a student that's sick or they're absent or they have their own headset at home, they can play any one of these avatar-driven, pre-recorded lectures and learn about how to do this. How do I estimate ejection fraction by doing a shortening fraction? Or how do I estimate it by doing EPSS manipulation? Or how do I just estimate how well or how poorly the heart is functioning by my eye? So just qualitatively looking at the echo screen, can I learn how to look at the left ventricle's contraction, the mitral valve leaflet's movement, and at the end of this, I can come out of it saying, I have a pretty good idea now about that's normal or that's abnormal based on what I've seen with these action buttons that show me what severe looks like, show me what moderate looks like, show me what normal looks like. So that's the hope, is that you can do these in group lectures, or you could do this completely by yourself. And, Dr. Kalbach and I have tentative plans to use a group of people that don't really do point of care ultrasound, and those are pediatric residents. It's not part of their curriculum. The only place that they would ever come in contact with that might be in the ICU or on YouTube if they looked it up themselves. And what we hope to do is put them through our 2 newly created cardiac POCUS modules, and then have them step to a mannequin that's linked to echocardiographic abilities. It's called Baby Works. So demonstrate what you learned in VR on this mannequin. We'll score them and then have them go to a patient. Show me those 4 key views of cardiac POCUS that you learned. Show me that you can do that on a real patient. And I'm pretty confident, even though cardiac POCUS is very complex, often a 2-3 day course that costs thousands of dollars to take. And I feel like the feedback from a lot of folks that come out of those courses is, I'm kind of overwhelmed. That was a lot of information in 2 days or 3 days. I still don't know how to do this. I'm pretty confident that if they go through our VR simulators, they're going to come away in about 20 minutes with, this very clearly showed me where I'm supposed to put the probe, what I'm supposed to see, and how this works and how I can interpret this. So we hope to put those pediatric residents that don't really have any exposure to POCUS through this VR simulator and then score them in real life and see how they do.
That makes a lot of sense. That's amazing. As you presented this at IMSH, how was the reaction? Did you get a lot of good questions, interaction? Like how many, how was it received by the participants there?
Yeah, I'd like to turn that over to Dr. Kalbach. He led that presentation.
Absolutely. Thanks, Nick. So yeah, I mean, honestly, overall, it seemed to be extremely warmly received. I'd say we had for the small group breakouts that we've seen on several of these, I think we had a very good attendance turnout for something like this, especially later into the conference. And those who seem to self-select themselves to attend such a workshop, I think out of those group, we had a high amount of interest, as well as people who were interested in collaborating from an educational standpoint, where they either have virtual reality setups or they have ECMO programs that would be extremely interested in collaborating with us in order to do either outreach or could help them get plugged in where we can actually either do education with them or kind of help garner them their own development of education from that standpoint. So hopefully in the coming weeks and months, we'll be kind of working with them as soon as we get ourselves fully rolled out here and a little bit more, comfortable with hosting some of those, and then we're hopeful in the near future to be able to start hosting at a national, if not an international level, where we can have people join us from wherever they are. We can hopefully be able to start for lack of a better word, hosting either full simulation events, or perhaps just impromptu or in situ smaller mini types of codes that are involved with these simulations. So.
Excellent. And for that internal rollout, what's next? Like, what are the next steps to make sure that it's utilized in-house before you start sort of hosting those external simulations?
Yeah, so Dr. Slamon and I, we actually just touched base earlier. We have plans to really formalize our curriculum. So when we were developing this simulator, we had very specific patient complications that you would typically see for a patient who is on ECMO. And some of those, whether it be perhaps a development of a pneumothorax or air around the lungs, that could impede our ability to perform the bypass, or perhaps cutting out of the circuit where it's not flowing for various reasons, whether that's low intravascular volume. And with those, what we would love to do is host these simulations and kind of in parallel have in-person ones as well. And what we would do is make sure our learning objectives for each of those would align. And then we could perform surveys, both pre and post, to determine, how well that they have, we could either say accomplish or they can retain this knowledge that they have gained through the simulation. So that is our current planned rollout for at least from the ECMO simulator standpoint. And perhaps Dr. Slayman can kind of touch upon some of the hopes for the POCUS.
Yeah, I think, John, as you're well aware, and Bill, I'm sure, is well aware that getting heads inside the headset is often the biggest hurdle and the first step. So since IMSH, we have not rolled out any real use of the ECMO simulator in terms of mock codes. Those are kind of the end goal. The real goal so far is to get as far and wide within Nemours itself with the word that this exists, come and see it. Maybe it's using the non-VR desktop mode as Rick has been using during the Zoom just to get people interested. But we found, and I'm sure you've come across this as well, that when people finally get into a headset is when the attitude changes, their world opens up, and they realize the capabilities, and this isn't just a game or a toy or something kind of neat. This is really useful. So, we're doing a little bit of a road show within Nemours where we keep inviting people to meetings, and then when they show up, whether their hair looks good that day or not, we're trying to put them in a headset and see if we can change their world and let them see what this is like on the inside.
100% converts on contact. I think Bill and I have talked about that many times.
Yeah, that's definitely the way to get it going. And we've done that with so many of our different groups that use Acadicus that we'll get some that'll just come in and be like, no, I don't think so, or but there's other ways, or those kind of things. And then you put them in the headset, it completely changes. Absolutely right.
Yep, that's the hope for sure. And with the POCUS, again, the residents, I think, are a little bit of a captive audience. They're there for 3 years with us, and they all rotate through the ICU, and they all seem to have a little bit of a skill deficit when they come to the PICU because they're paired up with emergency medicine residents that come from various different places like Jefferson and Inspira and Conemaugh and Christiana. The ER residents all come in knowing how to do ultrasound already. So the pediatric residents are really kind of at a loss because they don't have any exposure to ultrasound. So if we can kind of use that and close that gap, I think that would be important for the overall care of the patients in the hospital. If all of a sudden everybody can do an ultrasound, it raises the level of care and lifts all the boats in the harbor, so to speak.
I think you've answered both questions that I was going to ask next. I think the one was going to be how do you measure success? And I think Dr. Kalbach pointed to the surveys as an opportunity to gather some feedback on that. Is there anything else that you're thinking of in terms of metrics or measuring success to make sure that this is working and gradually make improvements over time, things like that?
Yeah, I think for the POCUS, for sure, being able to show them in VR the 3 key positions on the chest, and then bring them to the BabyWorks mannequin simulator and say, show me those key positions now, and demonstrate that you can put your hand on the probe and make that image come up on the screen is very measurable. Either you can or you can't, and we can score that very easily. Same with the ejection fraction. So it's one thing to be able to say with your eye, I think it's normal or it's not normal, but it's different to be able to go into the M mode, to move the cursor to the proper spot in the left ventricle and make the calculation between the diastolic volume and the systolic volume. And the VR module spells that out very easily. This is how you do it, and it's only about 4 steps, and it's very easy. I think if they can demonstrate that, yeah, I just like took a 10-minute tutorial in VR, it showed me how to do it, and I can step over to the mannequin and do the same, that is also, I think, very measurable and kind of an easy win for saying POCUS works when you train in VR. The ECMO measurements, I think Dr. Kalbach is correct that surveys are probably going to be our first layer. The second layer, I think, would be, running the circuit, assigning the incorrect modules where you see them. So the patient's bleeding at the neck. That's not supposed to be happening. Label that. Both of the cannulas are red. One is supposed to be blue. One's supposed to be red. That is recirculation. That's wrong. Label that. There's a clot that I can see in the cannula because I walked the whole run of the cannula as I'm doing my circuit check, and I found clot in several different spots, and I labeled them all. I think we can time that, and we can measure how many correct out of the total number of mistakes are in the room. I think that'll be very measurable as well. And then, as Dr. Kalbach was walking the circuit in our demo earlier in this podcast, it was clear that some of the things didn't match up. Like the pressures weren't right, but at the same time, you shouldn't have both limbs of the ECMO circuit be red. One should be very dark and desaturated, and the other one should be red if those are the pressures. I think, setting up that kind of mistake room is something you can do in 2 different ways. You can just label everything and say, find as many mistakes as possible. Even if it doesn't make sense, just label everything that you think is a mistake. The second level would be, let's make this a clinical scenario where maybe we have an X-ray with a cannula that on the X-ray looks like it's too deep. And that also is tied to the fact that there's some recirculation going on and the limbs of both sides of the ECMO circuit are too red. And maybe that also comes with a negative access pressure because the pump's trying to suck blood out of the patient, but the cannula is not in the right place to let you suck blood out of the patient. So have these kind of mini tutorials or mini tests where everything leads one to the other to the other. This is a mistake that would cause that to be a mistake, that would cause this third thing to be a mistake. Can they kind of logically put all the pieces together? It's one thing to say, I can find all the mistakes in this room. It's kind of like those VR hospital risk assessments where there's like blood on the floor and they left the railing down, like everything's a mistake. It's one thing to be able to kind of go through the room and do that compared to these mistakes logically flow for this kind of ECMO patient, that the cannula position is wrong, there's recirculation happening, there's negative access pressures, and the machine is cutting out. I found the 4 key things with one thing that fixes that, put the cannula in the right spot. So we hope to kind of have that second level thinking where it's not just I can identify everything that's wrong. I can not only identify what's wrong, but I know how to fix it as well. That would be the kind of the ultimate for the ECMO simulator, I think.
Yeah, and I think there's also something to be said too. And Nick, you'll have to remind me of the term because I'm not sure, not as an active part really of the fellowship, but some of the people who are involved in graduate medical education are familiar with things like milestones and things like that fellows have to achieve. But it seems like now that there's a momentum to change that to actual attainable skills, and I'm trying to remember the term that they use.
The EPAs, the
Thank you. The
protective
entrustable,
activities.
yes, the activities. And I think there's a lot of room for connecting these EPAs with actual ECMO skills, especially for the critical care fellows, um, and really going forward with how we can supplement those EPAs and really tie them together in order to actually obtain data to really show that these VR simulations are incredibly helpful and useful in retaining the knowledge and those skills associated with those EPAs.
That makes sense. And in terms of like the overall goal of the simulation, like you're saying, it's about proficiency with using this particular device, the system, and everything, and at a higher level, of course, increasing or improving patient care overall. Is there more to it than that, or is that kind of the main idea? You're just at the end of the day, we're trying to increase patient quality of the patient care,
I
saving
think you
money
said it
along the way
well.
too, right?
That is Yeah, I mean, that's always an added bonus, but the goal is especially with something as Nick said at the beginning of this talk, it's such a high risk, low incidence type of procedure, right? We want what's best, we want the absolute best outcomes for our patients. And it's really hard sometimes to make that connection going all the way back from education in a VR scenario to how our patient outcomes actually impacted, right? So I think the best thing is to start from somewhere, right, and show that your learners or your staff is acquiring new skills or solidification of their current skills, and at least make some sort of connection that can only help improve the outcomes for the patients that we care for, which tend to be honestly the sickest of the sick when it comes to this specific population.
Yeah, I
Makes
agree.
sense.
For a long time, medical education has been dependent on kind of see one, do one, and then teach one. Kind of see something, watch and observe, then do it yourself, whether it's putting in a central line or performing a lumbar puncture or taking care of a patient on ECMO, and then teach someone else to do it. And medical education has evolved in that, the time that residents and fellows spend in the hospital due to work hours restrictions has decreased and the acuity of the patients has gone up, but things like ECMO don't happen all that often. And it's probably not the best idea anymore to say, well, this is a teaching hospital. I just got to learn this. So I'm going to practice on the patient. Medicine is about practice. It's called a medical practice for a reason, but we don't want to practice and make mistakes on the sickest of the sick, as Dr. Kalbach said, if we don't have to. And simulation has always been a way to try to practice something that doesn't happen a lot so that you're as ready as you can be when it actually does happen in real life. VR has definitely plugged itself right in the middle of that. And I would challenge anyone anywhere to come up with a mannequin-based, pump-based ECMO simulator that can do all the same things that ours can do with the same level of immersion and realism as VR can. I just don't think that exists. And as you pointed out, for things where you need touch and feel and haptics, VR is still not there. But for immersion and realism and push button control of you want to do the simulation in the NICU? Okay, we can do it in the NICU. You want to go to the ER and do this? You want to do it in the operating room? You want to change the setting, change the parameters? VR is a button click that lets you do that. Whereas in the hospital mannequin-based simulator, it's all right, well, let's break down the simulator. That'll take a couple hours. Let's reassemble it somewhere else to get the idea of what would this be like in a different setting. That'll take 2 or 3 more hours. And let's hope that nobody needs the pump while we're doing all this.
Or let's
Absolutely.
hope that nobody needs the room either, right? We
Yeah.
have a simulator available like in an MRI suite where it doesn't happen often, but sometimes our patients do need imaging, right? And how are you going to hold up an entire MRI room in order to host a simulation to help learners understand what they should do in that type of emergency? So I agree with everything you're saying, though, Nick. There's just endless, I think, opportunities and uses and utilities for all this.
Well, this has been fantastic. I could talk with you guys all day long, but we're at the top of the hour. I really appreciate your time joining us today. I continue to appreciate our collaboration. I think everybody on, just speaking for everybody on our team, we continue to be honored to be collaborating with you both on this. And I think there's a lot yet to come. I think there's exciting opportunities ahead, and we really enjoy working with you. Appreciate your time today. Thanks, Rick, for taking us into the room in VR. So. Yeah, appreciate that. Thanks for joining Bill, Sean, and have a great weekend. We'll see you next Friday.
Thanks, everyone.
Bye, everyone.
Thank you, everyone. Take care.